Okay, so good morning everyone. Today we continue our last week presentation on the primary residence interesting cases, which is basically a quick review of some very urgent and very has to know cases. You have to know it because you might see it in your call and you might not have anyone to consult, and you need to know what's going on because it's very important. We'll have very quick review for the cases we saw last week. For example, this was a tension pneumothorax, exactly, and we talked about the way the mediastinal structures shift to the opposite side, and here was a case of pneumomediastinum, which was secondary to ruptured esophagus following forceful vomiting, which is called what? Do you remember? Syndrome? Borhave syndrome, exactly, Borhave syndrome. Okay, and here we have pneumoperitoneum, which can be normal if it is post-op, or it can be indication of a perforated bowel if it is no previous history of
surgery. This large amount of pneumoperitoneum possible?
Yeah, especially if laparoscopy, because laparoscopy they inflate the abdomen. They use gas CO2 specifically to inflate the abdomen. The trick is, after some people say 21 days you should not have any pneumotor. It can be seen up to 21, provided short. Every time you take X-ray, it's less. If it's the same or increasing, then there is something wrong. If you do X-ray after 2 days, and then after 5 days, and then after 10 days, it should be less and less and less and less. If it is the same or increasing, there is something wrong. Could be a leak or something like that. Okay, what do we have here?
So this is the ruptured point of the intestine?
What is a rupture point?
The right one. The point.
No, it's just the free air. You need to see the ruptured part. You need to give oral contrast, which is water soluble, not barium. Never ever give barium for a patient with suspected bowel perforation or leak, post-surgical or perforation. Any 1% chance of leak, you'd never ever give barium. Why? Because if barium leaks into the peritoneum, what will happen? You'll have peritonitis. You'll end up with severe granulomatosis, let's say, multiple granulomas from the entire abdomen. It has a 50% mortality, like half of the patient will die, and the other 50 that will survive, they will end up with severe adhesions that will make his life miserable for the rest of his life. So never ever give barium in any suspected leak, and don't allow it, and you make a huge fight if it was suggested. لازم تتعارك وتسوي مشكلة عليه، مشكلة كبيرة.
زين إذا ماكو أمنيون بريك
ما تسوي.
ما تسوي يعني.
باريوم ما تنطي. باريوم ما تنطي. You look for something else.
Water soluble.
لازم water soluble. لازم. Okay. باريوم it's a crime. جريمة بكل ما في الكلمة من معنى. Okay, here we have pleural effusion. Okay, we said the layering and the veil sign, and if you remember that. Okay, we're just reviewing the last week cases, rapid review. Here we have pulmonary congestion secondary to heart failure. You can see the upward diversion of the blood vessels. Okay, and what do we have here? We have the curly B lines. Again, due to the heart failure. Here we have the what? Aortic dissection, exactly, which is classified into two systems. We have the DeBakey and the what? Stanford,
I think
exactly.
Stanford more easier.
Easier, but I think DeBakey is more clinically based. Okay, and here we have an aortic aneurysm with ruptured and it's leaking contrast into the retroperitoneum with a mural thrombus, of course. What else we have here? What's this? Diaphragmatic hernia in a child. Okay, you can see the multiple bowel loops in the left hemithorax, and you can see the mediastinum shift. Even the endotracheal tube is in the trachea shifted to the other side, and paucity of bowel gases in the abdomen. Here you have the intestinal obstruction, exactly, very good. And you can see the multiple air fluid levels. And what's the normal amount or number of air fluid levels?
3 up to 5.
حفظوها 2 أبو 5 و5 أبو 2. Either 2 air fluid levels that's 5 centimeter in diameter, or 5 fluid levels that is 2 centimeter in diameter. So 2 أبو 5 و5 أبو 2.
This is practically or scientifically?
It's in the books, but practically you never have 5 small air fluid levels. Maybe 1, maybe 2, not more. Okay, and here you have the bean sign, the coffee bean sign, which indicates volvulus, sigmoid volvulus. And you can see here when they injected the contrast, again you have to inject water soluble, not barium, because volvulus is prone to rupture.
What about air?
Air is also a possibility. Air is a good possibility. CO2 they push sometimes. And in cases of intussusception in children, you also do reduction. Reduction happens in 2 ways. You have pneumatic reduction and hydrostatic reduction. Hydrostatic by using of water soluble contrast, or pneumatic. The thing is, when you do it, you must have a surgeon on standby. ما تسويها يعني على الله، لا لازم اكو surgeon موجود, because it can easily rupture and ends up into laparotomy. اي مثل جهاز الضغط، مثل جهاز الضغط. هو بي فالف، بي يبوش فالف يوصل لحد معين يقوم ما يدفع يليك. And طبعا it's done under fluoroscopy, so you see under fluoroscopy is it reducing or not. من يفتح راسا اذا كونتراست، الكونتراست تشوفه صاعد للكولون، اوكي that's it reduced. لا هو اذا من يوصل للبوينت اوف انترسبشن whether it is ileocecal, colocolic, يعني according to where is the interception.
There is limits. If it is at the level of the ileocecal, how this much of this amount of the air.
لا هو مو ليميت للاماونت اوف اير، هو ليميت للبريشر اوف اير. يعني انت تنفخ من يوصل ليفل معين، بعد تنفخ ما ينفع يطلع من الفالف. زين. And here we have what? Ascites, yes. You can see the ascites, and here we said what's the problem? The NG tube is folded back on itself, back into the esophagus. So we need to know the proper position of every medical device or tube or a catheter that is used, because it's one of our responsibilities to tell the doctors that this tube is in a good position, this tube is in a bad position, this disc cage is good, this disc cage is bad. It's one of our responsibilities to tell them. And again, we said here, this is the central line going back on itself into the brachiocephalic vein, and again kinking. And here you can see the endotracheal tube going into the right main bronchus, causing collapse of this lung and this lung. and it's a big problem. This can be all solved just by pulling the tube for a few centimeters. Never miss these things. They happen. I've seen it. They happen. You have to know that this tube is in the right or left bronchus and it's in a bad position.
Before 2 months, we had a case,
Mm.
the chest you put and perforated the lung.
Yeah, it happens. It happens.
It was inside
Yeah.
the lung.
Of course. Once, when I was a rotator, there's a cardiothoracic surgeon. No one knows what happened till now. He just put the chest tube,
Blindly.
of course, blindly, and all that came was pure blood, a gush, and the patient collapsed immediately. And till now, no one knows what happened exactly. Anyway, so it happens. Here we have the chest tube completely outside the lung. You can see it's within the subcutaneous tissues. I think we were here, right? No, this is also multiple fractures of different ages. We said fractures of different ages in a child equals child abuse, non-accidental injury. Okay, and these kinds of fractures, especially the one at the angle of the metaphysis, are very typical of child abuse, and this should be reported. These kind of fracture at the angle, they don't happen with usual accidental injuries, because in child abuse they twist the arm or the leg, and this kind of fracture happens. Again, you can see here in this child there is bilateral subdural hematomas. Here also another hematoma in a 72-year-old. Sorry? Epidural. What did I say? Subdural? I'm sorry. I mean epidural. And here there is an intraparenchymal within the brain stem. Of course, this kind of hematoma, usually it's fatal. It's very difficult to recover from this. And again, here is an intraparenchymal and the intraventricular. And here is Abihal?
The last case, I said.
Epidural, exactly. Good. And we talked about the difference. This one is intraparenchymal. This one is subarachnoid, exactly. Again, subarachnoid. This is intraventricular, and this is subdural with acute on chronic bleeding. So, يلا نبلش اليوم. يلا from the first case. Shilan, 58-year-old with headache. What is your diagnosis? This is typical. You cannot miss it. There is something here. No, I think she knows it. Here, something rounded, dense, and it's causing dilated ventricle, hydrocephalus. Okay, why it's causing dilated ventricle? Because it is occluding the foramen of Monroe, exactly. So what's this? No, hemorrhage is not rounded. Hemorrhage goes into the CSF. Anyone? Colloid cyst, exactly, colloid cyst. And by the way, one of the features of colloid cyst is that when the patient bends his head down, he gets better. Back, it occludes the foramen, causes the headache and the hydrocephalus, and then bends down and he's better. This is one of the signs that tells you this is a colloid cyst.
And it is high density because of proteinaceous.
Colloid, it contains colloid, proteinaceous fluid. Okay?
This is normal, choroid plexus calcification.
Yeah, it's we said 58 years old. This is after 16, 17 years old. This is normal. Okay? Now, while here there is a mass, where is it located? In the this occipital or posterior horn of the lateral ventricle, not temporal. Be careful. And it's a big mass, lobulated, and this is this is causing the marked dilatation of the ventricular system. So this is most likely what?
The age is important. So
The age is important, okay. Unfortunately, I don't have the age here.
choroid plexus.
Choroid plexus, papilloma. Yeah, over secreting CSF, causing this dilated ventricles. Okay. Again, you can see here, this is dilated ventricle, hydrocephalus, and the thing is you have to know whether the hydrocephalus is active or inactive. You know that just by looking to these things here. These things are this blackness, let's say. If it's MRI, it will be hyperintense on T2 weighted images. This is called subependymal flow. If you see this subependymal flow, means the fluid is flowing from the ventricle into the parenchyma, into the brain, because it cannot go away. So this is active hydrocephalus. It's happening now. And the earliest sign to look for to detect hydrocephalus is what?
Temporal.
The temporal horn.
Horn, yes.
Horn.
Yes,
Temporal horn of the lateral ventricle, this is the temporal horn, becomes prominent. Normally you should see just a slit like. If it is big, inflated, then this is could be early stage hydrocephalus, could be what?
Hypophyseal.
Part of brain atrophy. Either it's brain atrophy, especially in older age group, in patients who are Alzheimer and senile dementia and things like that, or hydrocephalus. So how we differentiate? You look at the gyri, exactly. If the gyri of the brain are prominent and big, then this is part of diffuse brain atrophy. While if it's hydrocephalus, the gyri and the sulci will be pressed against the calvarium and it will be effaced. It will be lost.
And if it is normal, it is normal pressure hydrocephalus.
Yeah, there is something called normal pressure hydrocephalus, also called Hakim-Adams syndrome. It has a typical presentation of hydrocephalus and incontinence with memory disturbance. 3 findings.
بس بالنسبه للبريفنتريكولار هاي
Subependymal flow, yes.
يعني هذا يعني شلون هو اهم يصير بالاوبستراكتيف
هو indicates obstructive.
اوبستراكتيف هذا
Indicates active obstructive hydrocephalus.
اللي هو نفسه
يعني it says that it will get worse. يعني it is going on. It's not finished. More. يلا محمود. 58-year-old woman with breast cancer and headache. What's your most likely diagnosis?
Metastasis.
Of course, breast cancer or cancer in general with a brain lesion. In 99%, I will not say 100, 99% if you have a brain lesion, it will be metastasis. The thing about metastasis, you notice they are enhancing. For example, here it's showing peripheral enhancement, sometimes peripheral, sometimes entire enhancement, sometimes homogeneous, sometimes heterogeneous, depending on the primary tumor. Okay? The thing about metastasis, if the patient is not receiving steroid, إذا المريض ما ماخذ steroid, you will see disproportionate edema.
Yes, between the muscle.
The lesion is like 1 centimeter and the edema is the whole hemisphere. يعني lesion very small will edema very big. This is to confirm that this is metastasis. If the patient is receiving steroids, you will not see edema or you see little edema. So when you see a lesion, you have to know, is the patient receiving steroid or not? If he's not receiving steroid and edema is low, then you might think of something else other than metastasis. For example, a primary brain tumor, for low-grade glioma, for example, meningioma, or whatever, depending on the occasion. يعني metastasis, if no steroid, you should see a very, very big edema for a small lesion. Okay? زين. Yeah, Dr. Bersheng, what do you think? These are 2 different people who fell injuring their neck. So, what's going on? let's start with this one. What's happening here?
In the right one, there is, I think, the third vertebral
Now, the A, يعني you mean? Okay. Low.
fracture, I think, in the posterior compartment of the spine.
Exactly. There is a fracture at the posterior column here of C2, posterior arch. This is fractured. We will explain in just a second. So what about this one?
This is grade 2, retrospondylolisthesis. or
Anterolisthesis,
anterior.
not retro.
The above. Yes,
Okay.
over.
So this is the whole spine is shifted anteriorly. You can see here there is fracture through the posterior element of C2 here, and the whole thing is disorganized. This is very risky. You can see the spinolaminar view line. It is not meeting all the vertebrae. This one is displaced. Okay.
فاسد looking يمكن.
You need more images to confirm.
رجع الصورة قبل.
أي فصل هذه؟
إيه.
على B?
إيه.
No, we are talking about A now. So we'll talk about. This is fracture of C2 called Hangman's fracture. Exactly. It is most common fracture of C2 due to hyperextension or compression through the pedicles of C2 with anterior slip of C2 on C3, and it is not associated with a neurological deficit. Okay, so this is A, while in B, the inferior articular surface of C5, you can see here, it's just like you said, locked. المفروض يكون over the superior one over the inferior one. Here the superior one is under the inferior one. It's gone from being anterior to being posterior. Okay, locked facet, exactly like you said. Now let's see, here we have two patients, one with pain in the ankle and the other with pain in the wrist. Okay, so what's going on here, Omar? They have the same kind of injury.
Same patient, yeah?
No, two different patients. One with pain in the ankle and the other pain in the wrist. What's this fracture called?
This is
Fracture that extends to the articular
yes.
growth plate, to the growth plate.
Growth plate, yeah.
It's called Salter-Harris fracture. Okay, exactly. Salter-Harris fractures. This one and this one, although in different locations, but they are the same type. They are all Salter-Harris, and we have 5 types of Salter-Harris fractures. You need to know them. I will not explain them. This is your job to memorize them. Okay.
But in this two picture, which one is more, let's say, bad prognostic?
Okay. Which kind of Salter-Harris is this? 5? No.
Yes, it's including growth plate and it affect the growth of the bone.
This is not. It's just reaching the growth plate, and the epiphysis is involved. So what kind of this? This is type 4. Okay. While here, from metaphysis crossing the growth plate to the diaphysis. So this is what kind? Sorry?
Probably
3. This is 3. Okay. So the thing with Salter-Harris fracture, the higher you go, the bad is, the worse it is. So this one will be worse than this one. Or sorry, no. Yes, this one is worse than this one. Yani 1 is simplest, 2 is little bit more, 3 more, 4 more, 5 more. Yeah, exactly. Not the severity, grading of what will happen in the future. Okay. Now, وين وصلنا هسه؟ أريج؟ يلا أريج. Easy. 27-year-old fell on the elbow. What is your diagnosis? Sitting in the emergency room, and they gave you this X-ray. What is your diagnosis? Don't describe. Tell me what's the disease. It's straightforward. يعني ما don't think.
Think better than bad answer.
لا bad answer better than think. Better than think and then bad answer. Huh? Come on, girl. Miran. It's obvious. Miran. صدق شذي.
Anterior fat.
Sorry?
Anterior fat sign.
Anterior fat pad is what?
For indicate fracture.
Bulging. And what about what else? غير الانتيرير fat pad. What's this? This is posterior fat pad. Okay? So, the posterior fat pad, usually we don't see it. If it is seen, it is abnormal. إذا تشوفها أكو مشكلة. Posterior. Posterior normally not visible. If you see the posterior fat pad, it means basically joint effusion. هو joint effusion. Okay? Normally we don't see it. If you see it, it's abnormal. High posterior. Anterior normally should be concave. Concave. If you see it bulging, convex, this is abnormal. واحدة أصلا ما تنشاف واحدة تنشاف concave. If you see it convex, هاي هذا الأسود. هذا fat loosened. Okay. It happens due to joint effusion. Normally this fat is between the two condyles of the humerus. You know, the two condyles. هذا it's buried between. When there is joint effusion, it bulges. The effusion push the fat peripherally. Then you start to see it. Okay, so you can see here. This is the posterior fat pad and the anterior fat pad, and usually this indicates a subtle radial head fracture. It's radial head, always radial head.
Posterior fat pad.
No, any posterior fat pad or anterior fat pad, not always, but most commonly, when you see it, there is a radial head fracture. Even if you don't see the fracture, you report the posterior fat pad is present, bulging of the anterior fat pad, findings are indicative of a subtle radial head fracture. Okay? لا, radial head. Most of the times it's radial head. Okay? هو subtle. This is the idea, subtle.
So you see it back.
You CT or MRI as you like. It depends on the orthopedic surgeon. They might just fix it. They might go for CT scan. Depending on the individual case يعني. Okay? زين. وين وصلنا؟ شو عندنا هنا؟ What's this? يلا بخال. There is dislocation of the shoulder joint. How many types of dislocation? There is anterior dislocation and posterior dislocation. Which one is more difficult to diagnose, anterior or posterior? Huh?
We see more.
You see posterior more. The vast majority of shoulder joint dislocations are anterior. You rarely see posterior shoulder joint dislocation. First. Second, posterior shoulder joint dislocation is much more difficult to diagnose by X-ray than anterior, because basically it will look like the same, like a normal joint. For example, you have to use special view, the lateral view, to see where's the humeral head relative to the glenoid process. For example, here, okay, it's not very well seen. I'm not convinced with what they're saying. The red arrow lies posterior to the glenoid fossa of the scapula. This is the glenoid fossa, and this is it's not obvious. It's difficult to diagnose. Okay, and you can see in the AP view the humeral head. This is a posterior shoulder joint dislocation. This is anterior view, normal view. If you are not careful, you might miss it for normal. It looks normal. You should be careful to look for this called light bulb appearance. If there is light bulb appearance, then there is a strong suspicion of a posterior shoulder joint dislocation. Usually posterior shoulder joint dislocation occurs in patients with what? Electrocution first. Second, patients who go for the يسموها الرجات الكهربائية electromagnetic pulse treatment شو يسموه؟ جماعة السايكياتري. Yes, the psychiatric patients will goes on electrical treatment. I forgot what's name. Okay, because they give them the muscles. They protect the shoulder joint. They hold the humeral head in place. So they give them muscle relaxant before treatment. So the muscles are gone, and when they give treatment, the shoulder joint no protection, it dislocates posteriorly. That's why you rarely see it. Vast majority of shoulder joint dislocations are anterior shoulder joint dislocation, like here. This is anterior. It's easy to diagnose. You can see the humeral head coming inferior to the coracoid process. Not only it's outside the glenoid, it's inferior to the coracoid process, and this is the most common. This is the one that we see normally. We rarely see posterior shoulder joint dislocation. Keep that in mind. Posterior shoulder joint dislocation is not very rare, it's rare. Okay?
كيس مال امتحان فقط.
بالضبط. Okay? هاي شغلة ثانية. If the patient have a recurrent shoulder joint dislocation several times, 2, 3, 4 times, then you start suspecting what? يا معودين يا الفاينل Hill-Sachs lesion. Hill-Sachs ويا شيجي Bankart. Hill-Sachs وبانكارت. Hill-Sachs, it's indentation on what? On the humeral head, while the Bankart indentation on the glenoid process. And the Bankart lesion, there is cartilaginous Bankart and there is osseous Bankart. إذا بس اللابرم, if only the labrum of the glenoid process is injured, then this is cartilaginous Bankart. If the bone is also involved, then this is osseous Bankart. And in cases of posterior shoulder joint dislocation, there is a reverse Bankart. The thing is, imagine the right shoulder, okay? This is the right shoulder, and the glenoid process and the humeral head. What happens, anterior shoulder joint dislocation, the humeral head becomes anterior and inferior to the glenoid process. This part of the bone, the supero-posterior-lateral aspect of the humeral head, hits the bone, okay? Causing indentation here. Okay, so when they reduce the dislocation and they go for an MRI, you'll see an indentation on the supero-lateral posterior part of the humeral head. This is the site of the Hill-Sachs lesion. While at the same time, if you have a Bankart lesion, this part hits the inferior anterior aspect of the glenoid. So you'll see injury at if the glenoid is like a clock, you'll see it at something 7, 8 o'clock. Okay? So they are in two different locations because they were in contact when they were injured.
One mechanism, one point of fracture, but when it relocated,
they will separate from each other. Exactly. So you'll see the Hill-Sachs on the posterior superior aspect of the humeral head, while you see the Bankart on the exact opposite, the anterior inferior part of the glenoid. Okay? And it's very important when you see the Hill-Sachs or Bankart, you have to report it because, and not only report it, even try to measure the defect diameter and depth, because it might affect the kind of surgery the patients needs. They need it. Okay? And by the way, bony Bankart, it's not that easy to see in the MRI if you are not suspecting it. إذا أنت ما حاطه ببالك you will not see it. Hill-Sachs, no, you see it. It's much easier. بس البانكارت خصوصا البوني بانكارت, which is the more severe one, it's not easy to see on the MRI. You might need a CT scan. Okay? If you are not thinking about it, if you know it and it's in your mind, you'll probably look harder and you will see it. Okay? So,
بس بالنسبه للبانكرت يعني هو موجود تشوفه يعني
you see the,
إذا
yes,
بدون-
you see the bony defect. Exactly.
لا،
So
مو
a
بس
case,
يصل
you
البانكرت.
presented a case.
It's not easy to see. I'm not saying you'll see it straight
مرات
forward.
الجلينو يطالع برا هيك مرات يعني هذا شلون تفرق عن البانكرت يعني شايف
Labrum قصدك.
لابرام سيرفيكال
Labrum, glenoid labrum, this is cartilaginous Bankart. نقول Bankart two types, cartilaginous or osseous. الosseous هو more severe of course. Okay? الosseous هو difficult. الcartilaginous easier because we see cartilage easier in MRI. For example, in the MRI you see the menisci easily. Okay? البون هو المشكلة. Okay? Any more questions? شو أخبار الوقت ويانا؟ Very good. Very nice. Okay, thank you.